All right. Good evening, everyone. Welcome to our first webinar. It's titled Billing and Coding Scenarios in Endocrine Surgery. Our panel today is Dr. Phoebe Zhang and Dr. Kim van der Veen. Both Phoebe and Kim need no introductions. They're amazing clinicians, and they also know a lot about billing and coding, and we're all hoping to learn something today. And my co-moderator is Dr. Rhett Long, who's been in private practice for several years and now is an academic, so he brings a wealth of information from both sides of the coin. So without further ado, let's take it away.
All right. Well, welcome everybody. Hopefully this will be educational and everybody will get something out of it. Okay, so very briefly, these are disclosures from Kim and myself, and then from our moderators. Okay, and then this is our big disclaimer. We are not certified coders. We have just a lot of hard-fought experience with coding and collaboration with coding experts. There are lots of coding gaps in endocrine surgery. So like the ESIC committee, for example, in the past has done a whole session categorizing the codes that don't exist for endocrine surgery for things that we actually do pretty commonly. And the other thing is this is a constantly changing field, like month to month, year to year, there'll be updates into the coding descriptors, and what you have been doing for a long time might change. And so hopefully we will be able to provide some of those updates today. And there are sometimes multiple ways to code one thing, and there might not be a single right way or best practice. It might also just be very specific to your institution. And so finally, like that's probably the most important piece, right? Like your coder at your institution will let you know what you can and cannot do, and they actually will be the final say. So our objectives today are to present some examples of the coding intricacy that can happen both on the outpatient side in clinic and also on in the operating room. And then we'll present some strategies and tips for improved billing. And then hopefully you will understand the importance of documentation. And then, of course, our goal is always for you to be compliant with laws and not go to Medicare jail. Okay, so we're going to start off with something very basic, which maybe all of you know already, but hopefully there will be some fellows and people that are new to practice that will not know. So start off with, what is an RVU? So this is a unit of work. It's specified by Medicare. There's this committee called the RUC that sets a work RVU and an RVU for each procedure. The component that we care about is the work RVU component, but there is also a component of it that is practice expense and malpractice. And these are adjusted regionally for regional local costs. And I would say that the migration in the US is most people are being converted to some sort of work RVU model. The dollar per RVU is going to be different than the dollar per work RVU. And in general, the dollar per work RVU is actually higher than the dollar per RVU. The conversion factor is a number that is set each year by Medicare for how many dollars they will pay per RVU. So for 2026, it's $33.40. But unfortunately for us, all of the work RVUs are being devalued by 2.5% this year. And you will see a lot of emails from the American College of Surgeons saying, email your senators, email your congresspeople, because there is legislation that is being pushed through to put a halt to this 2.5% cut. And so where do you go if you want to categorize all of your work RVUs and actually count up your work RVUs? So this is just one website that you can go to. There are lots of tools online, but you can go to this website. You could put in the CPT code, which is that 5-digit procedure code, and it will give you a work RVU number. One additional caveat for 2026 is that sometimes on these calculator tools, you will see a QP number and a non-QP number, and that has to do with whether your your facility or your hospital practice group is participating in a accountable care organization for value-based purchasing. If you are in one of those, you actually get some extra work RVUs, or rather conversely, if you're not participating, you get fewer work RVUs. Okay, so we're going to jump into this first scenario. This is a 45-year-old woman who presents to your clinic for primary hyperparathyroidism. You spend 45 minutes reviewing the records, talking to the patient, performing an exam, writing your note. You also perform an ultrasound to make sure that she doesn't have concurrent thyroid nodules and to localize the adenoma. So I'm going to send it to our moderators and ask them how they would code this. Okay, maybe we'll start with you, Rhett.
Yeah, so I think that first and foremost, in selecting an E&M code, based upon if you're billing for time or for complexity, based upon time, you're probably gonna end up billing a 99204 code unless you are somebody who's more accustomed and familiar with billing consultation codes. But in general, I would bill a 99204 with a modifier 25 to basically account for the fact that we're doing an in-office ultrasound, and then I would bill the ultrasound as a 765,536.
Great. Leon, anything you would do differently?
Um, just maybe a little bit. Incidentally, I had office hours today, and I literally had two patients with exactly the same situation. That was my last two patients, so I came home a little later. So I would probably bill this as a level five new patient, simply because A, I spent a lot of time, but due to the complexity of the situation, I did an ultrasound. I reviewed her previous imaging. Um, um, I reviewed the endocrinologist notes. I discussed multiple issues with her, surgical complications for thyroidectomy, parathyroidectomy, possible options. So I would probably bill this as a level five. And I also did a biopsy, so I would include a 25 modifier and a procedure that's in the office.
All right, perfect. Kim, anything you want to add?
I'm just going to ask, just for show of hands, like who's actually billing for the ultrasounds? Is anybody in the group billing for the ultrasound? I think we've talked about this before. You're billing for your CB's billing for ultrasounds. Not bill for my ultrasound for a number of reasons when this patient comes in. Number one, we have some problems with insurance, and we'll get to that on a slide up about, there's some, just like we have service fees of, what we're paid to do and insurance will cover. If a patient has had a recent ultrasound and it's already been paid by insurance, it may not cover for them to get a second one. So a lot of times I'm doing outside images. And again, look at some of those data points. I'm somebody that builds by complexity rather than time. I think for new people that are starting, time is just so easy. And it's totally fine to build by time. And sometimes you spend more time than you do complexity. But if you look at a grid like this, and a very simplified view of the AMA grid that you can use, if you put these numbers together and you take the highest two levels, and in this particular case, we're really deciding between a level 4 and a 5 visit. The scenario we've presented, I'm probably billing at the level 4 level, because so far of what we know now, we've got one fairly simple problem that is not going to have a whole lot of factors or other things in their surgical decision making, but we are be recommending an elective major surgery at some point, and I will have used the independent interpretation of an outside ultrasound and documented my own interpretation as one of my management data points. And so I'm probably going to be at high level on my data points, but maybe so far we've done it at the moderate level, either by time or by complexity. Rhett, do you want to, or Phoebe, talk about billing your ultrasounds and presentation?
Yeah, I think that and I think Phoebe and I do it fairly similarly, but I work at an institution now. I think we all have, various institutional requirements and individual practices that billers and coders that want different things. But when I moved into an academic practice, I had traditionally been either, trying to include the ultrasound as part of my E&M and the time spent with the patient. And then I realized from talking with our billing encoders at Dell Medical School that that really, in order to bill a clinical ultrasound, it required some key components, a not only a date of service, a clinical indication, but any prior films for comparison, or what I was actually you know comparing the in-office ultrasound to. But then I'll do a description that talks about the characteristics of the nodule, the heterogeneity, the echogeneity of the gland, and then I'll actually have to, document an impression the same way a radiologist would. Now, I don't go through every measurement of every nodule, just basically the ones that I feel like are clinically relevant. But in general, I try to document more things than not, because otherwise I feel that the code will get rejected.
I
I'm going
agree.
to also throw out, oh, go ahead, Phoebe.
Yeah, I do basically the same thing. I do also mention vascularity, and then I do explicitly mention the central and lateral neck lymph nodes.
One of the other things
Mhm.
that I add in all of my clinical notes of complexity is I actually put a template in that looks just like this chart of documenting what I did. And again, when you look back at that chart, one of the things that you might be talking about is a threat for bodily function. And when we're talking about somebody who lose hormone function, or again with severe necrosis or potential, decrement in kidney function from their parathyroid disease, if you document those things, we really are talking about fairly serious issues, even though the risk level may not be that. And so trying to do things in bill language, we like to do things in our medical talk language of, what we've been, taught to document for communication between us providers, and also to, our backs for medical liability. But some of what we're learning as we learn billing and coding is learning how we adjust our language to also make it easier for our billers and easier for our, institutions or our practice to collect on the work that we're actually doing.
Just to go back about billing for the ultrasound, just kind of to summarize, because I'm sure a lot of people are going to have questions. This question has come up in the past many times. If we want to bill for our own ultrasound in the office, you need to dictate a report similar to a radiologist, and do you need to save those images somewhere in your EMR or not? Can you guys comment about that?
You don't have to necessarily save it within your EMR, but you do have to have it in some sort of retrievable storage system.
Okay. And Phoebe, you mentioned in the past where if the ultrasound was already read and paid for by the insurance company, if you do the same read, you may not be reimbursed for that. Can you just mention that briefly?
Yeah, so that's on a subsequent slide. That's what Kim was
Okay.
referring
Sorry, I'm
to
jumping ahead.
earlier. No, not at all. As a frequency edit. And so, yes, so there are some insurers that will only pay for imaging of a certain area in the same modality in a certain period of time. So that's called a frequency edit.
Okay, thanks.
Okay, so we're going to add a little bit more complexity to this. So you do find a suspicious thyroid nodule on the ultrasound. Can you perform an FNA at the same visit, and how would that impact the billing? So we'll go back to Rhett.
So I think always we have to think about when we're discussing billing and coding, there's going to be things that are best for the billers and coders, and there's going to be things that are best for the patient. And I think that I typically will always offer to do a same-day biopsy for patients, because I think especially when you have to fight the downtown traffic and pay for parking in our garage, that most patients are more likely to come back and see you and recommend you to their friends if you're willing to be a one-stop shop. And so I typically do offer a biopsy on the same day as clinic, knowing full and well that one, that will require a separate modifier, as you see here on the screen. And then number two is that you're likely going to capture less charges for doing it same day. But I think in general, it's always important to remember, as we're talking about this throughout the evening, that doing the right thing may not always result in you getting paid more, but it's still the right thing. And so I definitely do offer same-day biopsies for patients that I'm seeing for an initial consultation.
Perfect.
I'm just going to throw out a question that's coming up with the chat. But relative to that, we are talking about diagnostic sounds, and we're going to be talking about some bundling and billing exceptions that come up later. When you're using an ultrasound to do an FNA needle biopsy, you cannot bill the ultrasound component. It's bundled or included in the CPT code that you're using to bill for that biopsy. I'm just going to throw back to Phoebe, just for our people who are new to billing and coding. Can you maybe just explain what a CPT code or a HCPCS code is and what an ICD code is?
Yes. So an ICD code, now we're in the 10th generation of ICD. So an ICD-10 code is a diagnostic code. A CPT code is a procedure code. And for professional billing, so the stuff that we do, we always use CPT codes. So your E&M has an associated CPT code. All of your procedures in the operating room have a CPT code. Where it gets a little bit confusing is that there are also ICD-10 procedure codes, but you will not be using the ICD-10 procedure codes. Your hospital uses the ICD-10 procedure codes. So for professional billing, the stuff that we do, CPT codes, but all CPT codes must be associated with a ICD-10 diagnosis code.
Same for labs. If you're sending somebody for labs, those labs have to be linked to an ICD diagnosis code.
Okay, so adding more complexity to this scenario. So your thyroid biopsy comes back as AUS with suspicious molecular, and you bring the patient back for a follow-up to review the results and finalize your surgical plan. Do you perform a vocal cord ultrasound at this visit? And do you do it with ultrasound or a laryngoscopy? And then do you try to pre-authorize some of these procedures? When you plan to take this patient to the operating room, what kind of codes are you going to try to pre-authorize? And then when do you make a decision for surgery? Or when did you make a decision for surgery in this case? So we'll start with Red again.
Yeah, so I think one thing I've learned over the years is that a follow-up and a pre-op visit mean very different things. And so a follow-up, especially in the situation that we're describing, when you're initially seeing a patient for primary hyperparathyroidism and you find something incidentally, well, all of a sudden you're talking about a new ICD-10 code, a new diagnoses. And so the decision to operate and what exactly we're going to do within the context of that operation has now changed. So I talk about this in the sense of a follow-up visit. Now, this can be either done in person, or I traditionally do these more as a video visit just to save the patient another trip to the office. But regardless, I'll talk about this as a follow-up to discuss new information and come to a new conclusion on what the operation is. And I think that's a critical point because a pre-op visit is not a reimbursable visit, whereas a follow-up where a decision for surgery is made is. Now, I think from talking to Kim leading up to this webinar, I think she taught me a lot of things about what to submit as far as some of the things that you're going to try to get pre-authorized, and I think her method for doing this is excellent. So I'll defer to you on kind of walking us through your process.
In terms of even the clinic procedures, I do laryngoscopy in my clinic. And again, I pre-authorize that. We pre-authorize the FNA. So moving back to the scenario at the beginning, I don't usually offer an FNA at the first visit because I sometimes don't have pre-authorization and I don't want the patient to get stuck with a bill for that. And just from a time perspective, how to push that patient through the clinic and make sure at adequate time. I don't often do FNAs on the first visit. But when we're doing these procedures in clinic, I do authorize them both for clinic procedures, same with RFA, pre-authorize those with insurance. And then when I'm prepared to go to the operating room after I've made that decision, because once you've made the decision, unless something substantive changes, you can't bill anymore for seeing that patient. If they got a cold and canceled their surgery and now they're out of their 30-day window, with their H&P and their consent forms. You can't bill to see them again once you've made that decision unless something has substantially changed. And so again, then we're moving on to authorizing with insurance. And I authorize all the codes I might use. And interestingly enough, most of our codes have been exempt, but Phoebe and I had this discussion this week about some patients of hers in a similar scenario where insurance was not allowing both codes to be pre-authorized. I'll let her talk to that. For me, I'm also adding on possible codes for pre-authorization, such as parathyroid autotransplantation. Because I've had surgeries denied payment over that transplant code because the parathyroid surgery required it was exempt, or the thyroid surgery was exempt, but the transplant code required pre-authorization. And so I've had, again, insurers not pay because they hadn't pre-authorized portions of it. If it's a cancer case, I might also be looking at pre-authorizing the neurolysis code, which I think comes up later in this presentation, of if you are freeing a nerve tumor, you can bill for that as a service, because that takes us a long time, and that's a risky thing that we do. And so again, just documenting how you do it, but I might pre-authorize that code if I think that that's going to be an issue. Phoebe, do you want to speak to that as well?
Yeah, so I actually have a case right now that I'm doing on Friday where the parathyroid portion is exactly the scenario. The parathyroid portion has been pre-auth, so the 60500 has been pre-auth. But I was also planning to take out a isthmus nodule that was causing compressive symptoms, and that portion has not been pre-auth. So I have a partial pre-approval right now for that surgery, but I'm just going to go ahead and move forward with the surgery. So it is very unique. I would say, like, it is always better to over pre-auth than under pre-auth. We wanted to also just talk very briefly about inpatient-only procedures. So this is eventually going to go away, but it's still in effect for 2026. So Medicare has a list of inpatient-only procedures where they feel like these procedures are high risk and can only be done as a inpatient status for the patient, which means that you have to certify that this patient is going to be in the hospital for at least 2 midnights. But then after you certify that this patient has been in the hospital or will be in the hospital for 2 midnights, if the patient meets milestones and criteria for safe discharge, you can discharge that patient early. But it is very important that you actually certify that these patients will be admitted to inpatient status, because otherwise your hospital will not get paid for this procedure and they will be very mad.
And to that point, I think some insurances don't agree. And so the insurance inpatient and outpatient rules don't agree. And this is where whoever's doing those pre-authorizations can be super helpful, because sometimes, for example, I had somebody that was getting a thyroidectomy and bilateral neck dissections. That's a lot of surgery. And thinking, like, I don't think they're going to make it out in 1 midnight. They're going to be with us a couple days. But it on the insurance list was an outpatient only procedure. So you can pre-authorize it as an outpatient only and convert those patients over to inpatient if they've required additional recovery time, pain management, IV fluids, or they haven't met discharge criteria. At the end of the day, you need the authorization, and then you may adjust either that early discharge or extended stay or transfer into inpatient status, as the patient progresses.
All right. Okay, scenario one. We're still in scenario one, but we're finally in the OR. So you perform a parathyroidectomy and a right thyroid lobectomy and an intraoperative ultrasound. You do PTH monitoring, and also you're doing your recurrent laryngeal nerve monitoring. So how would you code this case? We'll start off with Leon this time.
So yeah, it's excuse me, it's a combination case. So I would probably start with the portion of procedure that I guess will reimburse more, and the kind of more complex. I would bill this as a primary case as a right thyroid lobectomy with intraoperative ultrasound and PTH monitoring, and then followed by a parathyroidectomy, knowing that I'm probably not going to get reimbursed for the monitoring for the intraoperative PTH monitoring or the newer monitoring.
Okay, Rhett, would you do it a little bit differently?
Yeah, so my experience has been that the parathyroidectomy codes, ironically, even if a focused parathyroidectomy or one that might even take a shorter amount of time is actually a higher RVU allotment. So I would, especially given this scenario where the patient was initially referred to us for primary hyperparathyroidism, I would make sure that my operative report reflected the order in which the codes are going to be the highest reimbursed, knowing that with each subsequent code that it's going to be reimbursed less. So I would code this as, a 60500 for primary, or excuse me, for a parathyroidectomy. I would then document the lobectomy. And then document the selective venous sampling or code for intraoperative parathyroid hormone monitoring, since I draw those from the internal jugular vein and are actually drawing those myself. So I traditionally have not been billing for recurrent lesional nerve monitoring or for intraoperative ultrasound, just because I have had zero success getting those reimbursed. Although, of course, if you are using a company like Nirvana or some of these other nerve monitoring companies, that they can bill for that separately. So I would certainly start with the one that reimburses the highest, and that's the one for parathyroidectomy.
Kim?
This is tricky. So we're always talking about how everything's changing on a day by day basis and trying to keep up. So even since yesterday, since I saw this group yesterday, things have already changed in my practice. I've been under a auditing review, as an employed physician organization, and we're fighting over this, and they are dropping, allowing me to build the 36500 or selective venous sampling code, based on a pretty recent publication out of the CMS. And so, unfortunately, it's probably going to hit other people too in the near future. And trying to get around this is hard. I'm also still fighting with them over, significant additional service when we're talking about, distinct procedures services, which is a modifier 59, reduced services, which is a 51, 52, because we're going through the same incision. So part of that service is care and post-op care and risks build together. And so again, this is where that institutional piece of talking with your billers and coders is important, because as of yesterday, I would be billing both codes with a modifier, because that's what I've been doing for many, many, many years, adding in the intraoperative monitoring if it was doing that. Now this week, I'm going to have to do things a little bit different. And I talked about, sometimes it comes down to one word in your operative reporter language, whether you're using catheterization or cannulation, or how you use the language that the biller use. And so again, I'm with a that is entirely Medicare rules and is not going to play those games of submitting stuff to see if commercial players will pay, with different rules. So I'm unfortunately, as of today, now getting to drop that code and find a different way work around. It might be a modifier 22 for extra time, but again, probably I'm not getting my extra time.
Question.
Mm-hmm.
Um, as an employed physician, I don't generally bill the CPT codes in the OR. So how can I communicate with my billers and coders that I would like the parathyroidectomy to be billed first and a thyroidectomy billed second?
So this is going to be sort of institution to institution, but I do get a copy of all of the list of CPT codes by patient. It unfortunately comes to me in a 2 to 3 week delay, but I do get it. And then if I don't agree with the order of billing, I will contact my biller and let her know. I usually have about a week to email her back and say, I don't agree with the way you've coded this, or I don't agree with the order you've coded this. And we usually have to talk it out over the phone or over email.
For
So
people who generally don't have or haven't done that in the past, Phoebe, would you say it was acceptable for a surgeon to reach out to their coders and say, "Hey, can you send me a weekly, bi-weekly report? I want to see these kind of things." And what kind of report would you ask them? Would you ask the coders and billers to send to you?
Yeah, so we get two types of reports. One is automatically sent to us, which is you did this procedure on this patient, and these are all the codes associated with that encounter. There is another report that you can get if you want to keep track of your work RVUs. Our billing system is within Epic, so there's this magical system called the Cube, and your practice manager has to pull information out of but the cube, but it's basically it can tell you by patient all of the CPT codes that were billed. And if they're very transparent, they will also let you know with some time delay how much money they actually collected from that insurer for that specific CPT code. And then there is a work RVU calculation that is associated with each CPT code.
So quick
I think
follow-up
it's asking
question.
for a charge audit. If you ask for a charge audit, I think that's really important. I think in the learning realm, because again, we're all at different places in different parts of the country. And the problem with that is that they're kind of different, just like there's different practice paths, also different billing practices and kind of different standards and different interpretations of the billing rules in different locations. And so I think not only just asking for the charge report of seeing what's going out, but asking something like a denials report or finding out which things are going into either arbitration or requiring additional clinical information, or having to be appealed, a denials report, and getting that feedback from your coders can be helpful later. I get a weekly report just like Phoebe gets, and I have 5 days to make an edit or to appeal with my coder or have it go up to several layers of committees of appeals before it goes out. But not everybody has that. So again, trying to see what you have locally and ask for all of the data. Ask for the work RVUs, ask for anything that you can get. And you'll learn with time that some of the insurances, particularly the modifier 59 in Colorado, and we're in the Southwest, the Medicare, the Medicare grouping that with all of our things down here has specifically made requests what they want us to change things to. So they might, you want a 51, well, that makes the most sense to me based on the language that's in the book and what it might be. You send it in and they send it back and say, please change to 50. Great. So your coder should have that information about what's getting changed, where it's changed, and what you might change in your documentation for what you think is appropriate. And so I, in my documentation, will also say what was the primary diagnosis, primary indication for surgery.
Right, you had a question.
Yeah, just a quick follow-up question from Kim's statement of what you've just learned over the last 24 hours, and just a follow-up from a question coming from the chat from our clinical practice committee. To confirm, I've always been under the assumption that a anesthesiologist drawing PTHs from a peripheral line or from an A line is not billable. But are you saying that you've since learned that even if you're drawing your own PTHs from the IJ and using that 36500 code, that at least within your institution, you're now being told that that's not a reimbursable code? Is that accurate?
That's what they're telling me. They are using to send out that code. They're saying that is inherent to the procedure, and that was a committee decision of the highest at the institution where I'm at. But and again, that's based on how they are interpreting their language and rules, and that's something that everybody will have to continue to try at their own location. I think on the next slide, if we get to the next slide, there's another code that other people are using, which is the venous sampling through a catheter. With the supervision and interpretation. And so again, if you are not the one actually drawing, but you are supervising and interpreting the data, this might be another successful code for you. I'm going to go to my group to try and get this code. The bad news is that the 36500 work RVU code and the venous sampling interpretation code is 0.5, substantially less. And again, still made than 0. So I'm going to my team and say, what do you think about this? I am spending extra time. I think they're still going to tell know based on how they're reading the paragraph description of what a parathyroidectomy entails. And so again, I think it's going to be a moving target. Our white paper that went out, you want to speak to that? Because the white paper made some recommendations, and unfortunately, I'm not sure that CMS followed those.
Yeah, so in our white paper, we had proposed several codes that could be used as adjuncts, and one of them was this 36500 code, and that one did get get agreement from the ACS coding committee, so that is one that is in the white paper. But again, like, it all comes down to your institutional interpretation of the language. And so one thing that I would suggest that you do is you can go out and get your practice manager to buy the AMA CPT book, and it does get updated every couple of years. And you can actually flip to the paragraph related to the code, and you can write exactly what they want you to write in order to be able to build that code. And you should align your language to almost verbatim exactly what they write in their descriptor of the code. Okay, so we're still on scenario 1, part 4. You get the pathology back, and it's papillary thyroid cancer. So at your postoperative visit, do you just build this as a global, or can you also build this as a E&M of the new diagnosis of thyroid cancer? And then what happens if you have to return to the operating room for completion thyroidectomy for this patient? Or what about if your patient has any postoperative complications and you return to the OR? How would you bill in that case?
I'm going to
Leon,
pass
do you
this one
want
off
to
to
take this
Rhett.
one?
No, I'm going to pass this one off to
Yes.
Rhett.
Yeah, well, hopefully you're not having to return to the OR for complications, although as we'll cover here shortly, there are codes for that. But I traditionally am not. I'm still, as we've discussed, preparing for this presentation, that essentially all of our global periods are about 90 days, and so I'm typically discussing with the patient at the time of the follow-up visit, not pre-op visit, when the decision's made to do, a thyroid lobectomy as part of this parathyroid exploration. Counseling them on the risk of cancer and how this could potentially be cancer. So I'm not billing a new EMNM for the new diagnosis. I'm still billing this as a post-op appointment. Now, if there is pathology that would warrant a completion thyroidectomy, then I will then typically try to stage that about 6 to 12 weeks after the operation. And if it's within that 90 days, then I will bill the modifier for a staged procedure. But if they develop postoperative hyperthyroidism, that's typically also within the global period, in the 4 to 6 week range. And so I'm still not billing for that traditionally, although admittedly I could be leaving money on the table there.
Yeah.
When I sit in the auditor role, again, one of my side scenarios is peer review, and some of those peer reviews are actually medical necessity and billing audits, looking at codes and things are used, and it really comes down to your documentation. So there is room for, and it is legitimate for people to for a new diagnosis within a follow-up period that is thought to be maybe separate from what you already did. But it's all going to come down to documentation. In my practice, I've talked to my patients about thyroid cancer before we went to the OR in the first place. I'm not going to get to talk about it again or bill again because I already billed for it. And so I think, again, some of it's the documentation. If you didn't have that discussion and you didn't talk to them about the potential for adjuvant therapy and the regimen and the referral to medical endocrinology, the potential for radioiodine and what their long-term treatment look like, then yeah, maybe legitimately you can really bill for that extra time because there may be a lot of questions. Or if it's more extensive than you thought and you're talking about going for a second surgery, look at that as time, but you are definitely going to have a new diagnosis code. It cannot be linked to the original code that you had.
Okay, scenario 2. We we have a 40-year-old woman that has an asymmetric goiter where the left lobe is essentially normal, but the right lobe measures 8 centimeters with multiple nodules and extends beneath the clavicle. So you resect only the right lobe and then unfortunately devascularize and auto transplant a parathyroid. How would you code this case? Brett?
Yeah, so I think one of my favorite endocrine codes is the 60271 because it has the highest reimbursement of all thyroid surgery, with the exception of the modified radical neck dissection. So, I understand that the trick with that is though that this is a code that very explicitly says it's for a total thyroidectomy. So I always feel a little bit misleading, but when you're working for extra hour or so trying to finagle that substernal goiter, you certainly feel like it deserves more than just a 60240 or benign thyroid or 60220 lobectomy code. So I traditionally have used the 60271 with the 52 reduced services modifier. And then I will bill the parathyroid auto transplant separately as that 60512. And now, based upon Kim's excellent advice, I will start pre-authorizing that code, knowing that this is a high likelihood or potential for this operation. But I think that the key caveat being that if you do elect to go the 60220 route with a 22 modifier, that may be bundled within the payment. So that's just a very clear decision point that you have to make, is whether or not you're going to try to go for the bigger code with the reduced services modifier, or if you're going to try to go the 22 modifier route. But I traditionally have gone the 60271 because it seems like it's the most justified for the work that is entailed.
Yeah, I totally agree, Brett. So when
Leanne?
I started off in practice, I also coded the 60271 with the 52. And then I think I was about 3 or 4 years into practice, and then they told me I had to code it as 60220 with the 22 complexity modifier. So again, this is definitely going to be one of those things that will depend partly on your institution and how they are interpreting this language, although this language is getting more and more specific year by year.
I'm with you, Phoebe. I used to go so 271, and with time my coders pushed me to the 60220, and that leaves me with two problems. Number one, you know, a lot of times we're not getting paid for modifier two. So some of it depends on your contract. So we might not collect for modifier 22, but if I put the modifier 22 on there, I might get reimbursed for this, even though my institution did not. And so it's very contract dependent, but the modifier 22 is a lot of times not getting paid. And then again, I get into trouble with this auto transplant code, which again, some of the commercial insurances are going to go ahead and pay you for, and Medicare may not, and it may get dropped, you may get a code. And in the chat stream, there's a question about the documentation about parathyroid auto transplant. The billing is not something we have the ability to control. That's going to come from the insurance. They're not how they're going to read the rules. But in terms of getting paid at all on any, you have to make sure that your documentation of how you did the transplant is meeting the coder requirements, or reading the liner notes for what's involved in an auto transplant. So when you move that parathyroid, there needs to be language about outside of the operative field to a separate incision. That can be a separate fascial incision in the strap muscle, or in the sternocleidomastoid, or if you're moving it to the chest or the arm. But there's got to be those words outside of the field and to incision. And so, again, read the book and you just put the language that the book says, and get paid for the work that you did because you did the work. But we're not talking about doctor language. We're talking about coder language.
I'll just add that the coding paper does have some sample dictations that align with what is in the AMA CPT coding book. Kim, do you want to talk a little bit about assistant modifiers?
Sure. I think that there's a lot of people that are going to be watching the various different practice models. Some are going to be academics. And again, some people are on salary, people are on units, some people are on action, some people have base salaries, others don't. Most of us have some element of RVU if we're on production. So when we're doing different things, we have to also be compliant with our assistants. So I use independent surgical assistants that separately bill. Some of them are out of network at times. Sometimes my PA or NP is with me. Sometimes I have a hospital-based assistant. If you're at a teaching facility, and I'm at a teaching facility, but I don't currently have residents assigned to me, so I have to always write the language when I have an assistant that's not a resident that a qualified resident is not available. The other thing that's kind of interesting about that, if you're that very difficult substernal goiter and you've got the brand new intern with you and they just don't know how to hold the retractors and they can't be particularly helpful, and you call your partner in to help with that case, again, what constitutes a qualified resident is your decision. And so again, you can have a resident be present, hopefully not, but present for the case and learn from the case, but you then need to document why you had somebody else serving the role as first assistant or why that resident wasn't qualified for that role. And that's not a big deal. It just has to be in your documentation. I do a fair number of combination surgeries. I'm working either with my head and neck colleagues or with my cardiac colleagues. And so for some of these codes, again, if we're doing a sternotomy and they're going to put in some sternal plates for me and other things, we're deciding how we're going to, parse out different codes, or maybe my patient's going to get a laryngectomy as part of, the procedure we're doing, or I'm doing the right side of the right lateral neck and you get the left side, and we decide who takes primary and documents for the codes that they do, and then who might then take an assist code, because we're not going to get paid that much for an assist code. And Phoebe has some great examples because this is contract dependent for a lot of employed physicians. Otherwise, it's Medicare rates and Medicare dependent. And so again, if you do a co-surgery, you have to to write in your documentation why you need two surgeons. And so it's a little easier to do if you're from two specialties. But each surgeon then also has to document the operative note. So the primary surgeon has to document if it's a primary and assist situation, but co-surgeries have to have documentation from both physicians. Phoebe, do you want to talk about how great of rates you got for assisting when you had really great support?
Yeah, so just like Kim was talking about the other modifiers like 22, right? The assistant modifier is also really interesting in what the insurer pays you or what Medicare pays you might not be the same as what your institution is willing to pay you for that modifier. And so my first job, I was actually at an institution that was very generous with assistant work RVU credit. And so even though Medicare would only pay them 16% of the rate for whatever they collected for assistants, if you were the assistant, you actually got 100% work RVU credit. So that's not common. That's very rare. But there are institutions that could possibly give you more than 16% in terms of work RVU credit. And I will say the same thing would apply for something like an unlisted code too. So unlisted codes actually are associated with no work RVU. So you would actually have to individually work out with your institution, if you are work RVU based, how much that procedure is worth. So we have a couple of other things that we didn't have time to mention today, but could be the focus of a subsequent coding and billing webinar. But there are obviously thyroid ablation codes that are new. There are many modalities where there still isn't a level 2 CPT code. So only for focal ablation, only for thyroid, only CPT codes exist for RFA, but not for microwave, not for PFA. So that would be a challenge at your individual institution on how you're going to get credit for those. We talked briefly about unlisted procedures. So again, unlisted procedures have no work RVUs assigned to it, but your institution has to figure out how to pay you for that. And it's either going to be a flat fee for a procedure, or they're going to convert it to some work RVU number and pay you off of that. We didn't have a chance today to talk about shared visits. So I work with a PA. Some of you will work with a PA or an NP, and you're going to have to share billing or shared visits for those interactions. And then we wanted to just highlight some difficult codes that where like there isn't a great code and there's multiple ways to code for a procedure. So like one that we had considered putting in the coding guidelines, but ultimately didn't make it into the coding guidelines was thyroidectomy with modified neck dissection, right? Like this is a one where it could be coded multiple different ways. Reoperative central neck dissection. This is also one where a great code does not exist. And then isthmusectomy. Is it a lobe? Is it just a nodulectomy? That one is also an area where there's a lot of ambiguity. And then incidental parathyroidectomy during a thyroid procedure. And then finally, parathyroidectomy after prior neck surgery. Is that considered redo parathyroid or is that primary parathyroid? So that one, there's actually some guidance in the white paper. And that was one where the ACS coding guidelines committee actually did agree with us that a reoperative field should be considered a reoperative parathyroid, even if the index neck surgery was not a parathyroidectomy.
Kim, can you just say what's the easiest and best way for people to find that white paper that you mentioned several times? Where can we
Oh,
find
I
them?
think I think we can, you can we have it uploaded on the AAS site. I think it's in the member
Okay.
area. I think, isn't it?
Yeah.
I believe it's in the member area. You can also, search Google and it can find it for you. But I think it's in your member of your AAS as one of the publications. We usually have it linked with anytime we do one of these billing presentations as supplemental material. So we can try and have that link so that you put the supplemental materials for this too.
I read that paper. It's excellent. It's thick. It's dense. It's definitely useful. And shameless plug, it's one of the awesome benefits of being an AES member. Just log in. It should be there.
Yeah, so another shameless plug. I would, as we're wrapping up here, I would ask, with the wealth of experience in different practice environments that we all have, I would just ask for our panelists just to share what their compensation model is, and for our new, for our fellows and recent grads, what is the model that they should, what are the questions they should be asking in terms of their compensation? What's maybe the best model that you've seen or that they should try to negotiate for? Maybe if everyone could just kind of share their experiences and maybe give our trainees and young faculty some advice about how to set up their practice and how to discuss these types of things with their billers and coders.
I can go first. So I'm in an academic practice, and we are pure work RVU after the first 3 years. And so we have a dollar per work RVU that is fixed, but it does vary based on your academic rank. So each step up is about a 20% increase in the dollar per work RVU. And that's been the system that I've been in for the past 3 or 4 years. I will say that when I was a fellow, we were in a very unique system, which was a blend of collections versus work RVUs. And so, where a collection system would benefit you is if you have a very favorable payer mix. So, if you're seeing like sheikhs from Saudi Arabia, or if you are seeing only commercial patients, then a collections-based work or a collections-based system would be very favorable to you. If you are in an area with a very poor payer mix, if you can negotiate a relatively reasonable dollar per work RVU, it's actually better to be in the work RVU model.
I guess I'll go next. I've been in a bunch of different systems. So I've been in 3 different employee models with hospital systems. They've all had different pros and cons to them. I've also been in private practice, owning my own business. At one point, I even started a physician management group where we were doing some billing and trying to manage and run some practices that didn't go so great, I would say. But in terms of recommendations, I think it's really hard to be in private practice because the compensation just keeps going down and down and for professional fees, and unless you're where you're getting a portion of the facility fees, then it's really to run your business just on professional fees alone. You go back to that, that slide where we talked about the conversion factor. If you're talking about getting $33 per work RVU as your rate, depending on your payer mix, and a good payer might be that you settle out around 100 to 130% of Medicare in your total practice. How do you keep the lights on and pay your staff and pay yourself and pay your malpractice on those professional fees? You don't. It's really hard unless you have ownership, or your group, if you're in a bigger group, big group has ownership. So the other, I like to just remind the young people that are coming in, and well, this is what I'm worth, and this is how many dollars per do I'm worth. Just remember that if you're more than 33, those more than 30 are coming from somewhere. They're coming from for fees or really great contracts, and or physician service with health systems or other places. And so again, I think Phoebe, you have information about kind of what the going rates are, and the $50 or $60 per RVU are kind of going rates for new people into practice. Just think about how much money that is. That's a lot of extra money that come from somewhere to pay you, to pay your health insurance, to pay your staff, like where the rest of that money's coming from. And so again, just for people to keep in mind of, when we're talking about these work RVUs and what's a standard RVU and a median work RVU. But I would also tell people, keep track of your numbers. When you start in practice, you get a salary guarantee. How many RVUs are expected to meet that or exceed that salary? And then again, really, is that reasonable salary or amount of work to get done?
Well, Kim and Phoebe, I really appreciate this. It's been about almost exactly an hour. I think we've covered a ton of information. Thank you so much for your insights and your experience. Um, I feel there's going to be a follow-up webinar to this, because this was a lot of good information. I'm sure a lot of people are going to have questions in the future. We'll figure out a best way to post this and to have as many people have access to this. And hopefully we'll be able to revisit this topic and do kind of a question and answer, either live or recorded again, to answer people's questions. Rhett, anything else from you before we close out?
Yeah, I just want to say thank you, and I anticipate a lot of interest in this, and we understand that we by no means covered everything that can be covered in this realm, and we look forward to yeah, additional webinars and or potentially doing something live where you can ask our excellent and experienced panelists questions that may be more specific to your individual situations. But we hope you enjoyed this evening, and if you have any questions, feel free to reach out.
Thank you,
Thank you very much,
everybody.
everyone.
Thank you all.
Have a good night.